Thank you very much for the invitation. I'm very proud and honored to be counted amongst the speakers of the BAOMS, enjoying this session. I would like to start first by asking for indulgence. I'm sure you'll have some sympathy with me on this topic because it's not an easy topic to get around on. I would also like to directly admit that I'm not an expert on either China or Asia. So hopefully what I'm going to give you is my own perspective, which let's hope will be appropriate. Okay, in the next 50 years, I think we can't talk about the next 50 years without taking a general view. The general view about the population. You will see from this that we have a fifth of the world population essentially being the richest, while the 4/5 are carrying on with less than 20%. This is just the background that I think is important to understand. The population growth, if you look at this graph from 1750 and projected until 2150, you'll see that the explosive growth in population is basically involving the less developed countries. The more developed countries are continuing on a steady state. And it's a large number. We're reaching nearly 11 billion by then. But global economic development is something which is very different in different groups of countries. The least developed countries are only 1 billion, and the most developed are another billion, with nearly 5 times as much in the so-called emerging economies, which include China and many parts of Asia that I'm supposed to be involved in talking to you about, as well as a few of them in the least developed column. So that's the background. Don't forget that economic development is not uniform. It's not the same way across the spectrum. Urban versus rural. We have 50% urban societies at the moment in the world, rising to maybe 70% by 2050. Healthcare has moved from the industrial age concept to the information age concept, although many countries are still lagging behind in the industrial age concept. I'm sure you recognize this. If you look at the industrial age medicine, you will see that in those days, spending was not an issue. Encouragement was to develop further and further into technology and into higher specialization, with primary, secondary, and tertiary levels of care being promoted, and the professional being at the top of the heap. Whereas as we move into information age, we found that the most important is no longer the professional, it's actually the individual patient and the recipient. And along the way, the professionals become facilitators and helpers and partners, etc. And that's quite a different thing. That brings in a different approach to the way we function. The background in relation to our specialty, I'd like to divide this into the last 100 years onwards. The last 100 years, if we look at them, I'll look at the first 50 years, which are the years between the two wars. I'd like to think that these were the years of invention, and I will elaborate in a minute on this. Whereas the second 50 years after the World War II, these were years of consolidation. And the last 30 years, that means 30 out of the last 50 years, 1980s onwards, I think these were the years of sophistication. I would just like to elaborate on this a little bit. Looking at the time of invention, what I call invention, I think this was the time of scope expansion. And Andy Brown did a great job with that, and I hope I'm not repeating his thoughts too much. We moved from a dental time using trauma and involvement in trauma and onwards to reconstruction. This was the scope expansion, I think, at the time, whereas after World War II, in the consolidation era, we got role recognition. We got hospital services, and we were responsible for trauma services, and our role in the hospital as surgeons became recognized. And the last 30 years, 1980s onwards, sophistication is really, became recognized as experts. And that includes cancer surgery, microsurgery, computer-assisted surgery, navigation, research and development, and not to forget ethics, These are all part of sophistication that we've reached. At the same time as our specialty was moving through those things, we have technology and communication and a globalized economy that was exploding, as Andy said, on us. Travel, just think of travel and the internet from the 80s onwards, where we didn't have it before then, and what it's done for us. And what it has done is it has a huge impact on public awareness and education. Public expectations have changed dramatically, increased significantly. And with that, standards of practice have developed, and our accountability is not recognizable as compared to some years before that. All of those have influenced our specialty and ourselves significantly. Starting with the thought about the next 50 years, remember the population increase that I mentioned. This is going on as we speak, affecting the less developed countries. And again, remember that economic development is not uniform. And with that, there seems to be a growing gap between available care and affordable care. So, you know, you look at your NHS and how that's going in terms of finances. That's really a problem across the world. Medical tourism has developed because of that. And what's happened is there is tourism of patients from developed countries to less developed countries to get their treatment. There is outsourcing by the insurers and by service providers in the same direction to get cheaper care. But there is also foreign recruitment of healthcare personnel, but in the opposite direction, from less developed countries to more developed countries. You can call it brain drain, or you can call it actually active recruitment. So medical tourism is surprising, and I'll just digress for a moment. Malaysia received 100,000 medical tourists in 2005. Singapore, 200,000. 500,000 went to India for medical care in 2007. By 2012, medical tourism was giving 2.2 billion into India's economy. And 2008, it's a $60 billion global business. Growing at 20% per year, the estimation is. So that's a digression on where we are, despite what I mentioned earlier. There is also a trend across the whole world, both developed and developing countries, and that is the rise of the middle class. Living in the cities, good purchasing power, aging population with chronic diseases, better informed people because of the internet, and willing to pay out of pocket for healthcare. In the developed societies, they're willing to pay out of pocket for single events, like cardiac surgery, renal transplant, whatever. In the developing countries, the emerging societies, they're willing to pay out of pocket for everything to do with healthcare. And they don't want to wait. So this is part of the background. Moving on to Asia, well, we've already heard something about this from Africa. Asia is similar in a sense. We have poverty, we have political instability and war. We have corruption, different pattern of disease, lack of facilities and services, and significant cultural and religious influences. Bear in mind that professional development in those countries is not uniform. Looking at education, what stands out is China in having a so-called stomatology educational background, whereas the medical base is in the French-based countries, Vietnam, Laos, and Cambodia. Everybody else is based on a dental education, including India, Indonesia, and all the others you can see. Japan, Korea, Taiwan particularly form a different group. So this is already a different base to start off with when we're talking about the future of our profession. There are inherent strengths and weaknesses in this sort of background that I've just painted for you. For example, and I'm not going to say which is the strength, which is the weakness. I'll leave that to you to work out. Stomatology, I think, relates to scope of surgery. In this case, I think the scope of surgery based on stomatology in China is much wider than our traditional dental base that we have had in the other countries. But there are different standards across the same country there is a different standard in the capital city as compared to the rural center. And there are differences in the ethics of practice and research, which we have to keep in mind. And the rate of progress and development is different. It varies with the language, which country you're dealing with in Asia. And also, there is a big opening towards being part of our international community of the profession. And I give just one example. Scientific publications. China and Brazil are the highest rising number of manuscripts submitted in the world at the moment. The most incredible increase in number of papers received are from China and Brazil. Another point I'd like to bring out is there is, in terms of scope of practice, the scope of surgery that we do, there seems to be a disconnect between training and practice. There is, in the developing nations, we have practice beyond training, while in the developed nations, we seem to have training beyond practice. Take, for example, in America, where people restrict their practices voluntarily despite the training. And that leads us to a situation with our specialty where there is maybe an issue with identity definition that was alluded to from Latin America. I think the issue between medical, dental, and surgical goes beyond the degree issue and the training issue. It's also to do with public perception. The legal status in Asia, for example, what is the legal status of the dental profession of oral surgery? The practice privileges which are given or not given in the hospitals or otherwise, and the compatibility of actions by our professional colleagues versus the perceptions. All those play into our current existence and the future, and they have to be handled. The next 50 years, I think, there will be development of international standards. Accrediting bodies in the domains of quality of healthcare and medical education will probably burgeon, will be developed further. There is already such activity going on in accreditation of hospitals. There are also attempts at accrediting medical education, medical schools across the world. People are going to medical schools across the world and coming back wanting to be recognized in their own country. There is also the emergence of privately financed corporate specialty hospitals. Now, you all know this is to do with medical tourism as well, but it's not only that, it's also endorsing and strengthening the source of this medical tourism. So in the emerging economies, there are super specialty focused hospitals focused on out-of-pocket paying local middle class or visiting middle class, coexist with public hospitals without any cross-subsidy, capitalizing on lower-cost labor force, but willing and able to institute a culture of quality and transparency in reporting their outcomes. And they're expanding regionally and competing globally. And this is set to continue in the future, I think. I think there will be setting of global standards. There may well be common multi-sited undergraduate and postgraduate training programs where there is a shared curriculum with multi-site training, with common evaluation methodologies and benchmarking across countries, cultures, and systems. And of course, to complete that, there has to be uniform institutional accreditation, provider licensing, and certification, where you end up with a common licensing examination and multinational board examinations and certifications. These are currently being debated, not accepted by many people, struggling with it, but I think the trend is that way forward. What are the opportunities? International collaboration in research and clinical treatment, but also international guidance from the seniors, from the well-developed places, and partnership with the less developed in training, in accreditation, and examination and certification. The British have been doing it for many years with the Royal Colleges, but I think now it's going to spread beyond the Royal Colleges into other people across the world who aren't going to, because, you know, with the British system, your own standards have to also apply elsewhere. At the moment, your standards are different from where you go out to actually provide this help, and it's not taken very well. I think it's a double standard problem. And I think the international standard is going to be the same, but those who can't take it up won't, and those who can should. Research summits, international committees, multi-center studies for essential questions in our specialty, consensus on outcome measures and priority areas for our specialty as a whole, I think would be the way to a future for research. And in terms of the real future of the specialty, I think we do have to maintain pace with progress. We have to evolve our scope to maintain relevance. Relevance is important. We can't look like we live in an ivory tower doing what we like to do while the real work that the people need is done by somebody else. That's a danger. Maintain our standing in the community, internationally I'm talking, of course. And the major challenges are division of the specialty, because the weak will end up numerous and they may displace us because we are not unique if we don't include some of our scope among our specialty. Reduction of services is a problem, and voluntary withdrawals by individual surgeons from the main scope of our practice is another danger. Good talent goes wasted doing lesser things. The emerging economies, therefore, in conclusion, they have the best and the worst. They have skilled doctors, but poor facilities. They even host medical tourism. But the general population is underserved. Government allocation of funding is low. In the short term, they depend on charities and assistance. And in the long term, they need education and training. Mr. Chairman, President, thank you very much for the opportunity.